So part 2 of this lecture on mixed radiopaque radiolucent lesions is now on tumors, and we have 4 examples: calcifying epithelial odontogenic tumor, adenomatoid odontogenic tumor, calcifying cystic odontogenic tumor, and ameoblastic fibroodontoma. So starting with adenomatoid odontogenic tumor, this one is mostly found in the second decade in about 70% of patients with an average age of 16 years. So what are the radiographic features? Location. So at least 75% of them will be found in the maxilla, in the canine region. And then how is the periphery? It's usually well defined, corticated, or sclerotic border. So this is such an example of a lesion that's found in the maxilla. You can see that this is a young patient, and the lesion is you find it's periapical. It's periapical to the deciduous molars there. Yeah, and then you can see the premolars, the developing premolars, which are found there within the lesion, and probably the lesion will cause the impaction of those teeth. We find that within the lesion, this is a lesion where it's we find a radiopacity within the lesion. Then we find a border which is sclerotic. So the internal structure, you find radiopacities that develop in about 2/3 of cases. So usually it will start as a radiolucent lesion, and then radiopacities will appear within this lesion. And it can also be completely radiolucent. Then intraoral radiographs may be required to demonstrate the calcification within the lesion, which may not be seen on panoramic radiographs, because the intraoral radiographs have a better resolution. They will be able to show the calcifications within the lesion. What are the effects to the surrounding structures? So as the tumor enlarges, the adjacent teeth are displaced, like we've seen, and then root resorption is rare. Then this may inhibit the eruption of the involved teeth, like the premolars that we have seen in the previous image. Then it causes expansion of the jaw, but normally the outer cortex will be maintained, so to really perforate the cortex. So what are the differential diagnoses? So this lesion may appear like a follicular cyst. So you rule out if the attachment of the radiolucent lesion is more apical than the cemento enamel junction, and if there is a calcification present. So the follicular cyst, you find it in the pericoronal area. So if you want to rule out if this lesion is a follicular cyst, so you'll be looking at the periphery as the attachment of that lesion, whether it is at the cemento enamel junction or not. And then within the lesion, if you find calcification, then you're sure it's not a follicular cyst. But probably early, before the calcification develop, you may confuse it with a follicular cyst. That's why histology is very important. Another differential is odontogenic keratocyst. This is especially where we don't have calcification happening. And then the cystic calcifying odontogenic tumor also occurs in the anterior region. So it's also another differential. The ameoblastic fibroodontoma, another differential, but this one will be commonly posterior. Can also be the CEUT, but this one is commonly posterior and found in older individuals. So number 2, let's look at calcifying epithelial odontogenic tumor. This one is less aggressive than the ameloblastoma and is found in about the same age group. Eventually, this tumor they may have an extraosseous location that is out of bone. So it's more common in men with an average age of about 42 years. It causes jaw expansion. What are the radiographic features? So it's mostly found in the mandible with a ratio of at least 2:1. And then you find it in the molar area with a 52% associated with an unerupted or an impacted tooth. The periphery will be well defined and have a like cyst-like, and then to be irregular. The internal aspect, this may appear as a unilocular or a multilocular with numerous scattered radiopaque foci of varying sizes and density. So the most characteristic and diagnostic finding would be the appearance of these radiopacities, which are close to the crown of an embedded tooth. We'll see an example of that. And then the effects of the surrounding structures may displace a developing tooth, or it may prevent its eruption. It can also cause expansion of the jaw. What are the differentials? So lesions with completely radiolucent internal structure may mimic dentigerous cysts if they are pericoronal or ameloblastomas. So the other lesions are with the radiopaque foci, will be the adenomatoid odontogenic tumor, the amelofibrodontoma, and the calcifying or the cystic calcifying odontogenic tumor. So, however, the prominent location of the COT and the age of the patient will help in the differential diagnosis. So, with the COT, we find it more, it's posterior, and then the patients are older. This is a radiographic example of that. So, you find we have areas that are radiolucent, and then we have areas with a calcification inside. So this is calcification within the lesion. And you can see the teeth are fully developed. So this is probably an older individual. Then we come to the calcifying odontogenic cystic tumor. Okay, it's uncommon and slow growing, and it's a benign lesion. It may have a calcified tissue within it, which may be identified as dysplastic dentine. And in some instances, the lesion is associated with an odontoma. So sometimes they contain more solid component that gives it an appearance, resembling an ameloblastoma. So for the location, at least 75% of them, they will occur in bone with nearly equal distribution between the upper and the lower jaw, and mostly they will occur anterior to the first molar. Cause the periphery to be well defined and corticated with curved and cystic-like shape, or ill-defined. It could be ill-defined and irregular. Internal structure could be completely radiolucent or may show small foci of calcified material that appear as white flakes or smooth pebbles, or larger solid amorphous masses of radiopacities within the structure. Effects on the surrounding structures. So 20%, 15% of cases will be associated with the tooth, and most commonly are canine, and to impede its eruption. And then can cause, as it grows, it causes a displacement of teeth and resorption of the roots. And occasionally may cause a perforation of the cortical plate. So what are the differential diagnosis? So one is a dentigerous cyst, especially if there are no internal calcifications and the lesion has a pericoronal position. Then other differentials would be those are the tumors that have calcification within them. So the radiograph displayed there, we can see this is a patient. The patient who has a heavily restored dentition. Then we see a tooth which is impacted there, and it's surrounded by radiopaque calcifications. There are calcifications around the crown. So you can see, and then around it is a radiolucent. So radiolucent lesion, and then within it we have radiopacities. So one of the radiopacities is a tooth, the other radiopacity, or probably there are now calcifications within this lesion. Then we come to ameloblastic fibroadenoma. This one is rare and mostly monolocular. Can also find some that are multilocular. It's a mixed lesion. It resembles closely the ameloblastic fibromas. We find it in children and will either contain enamel or dentine, either as multiple or small opacities, or it could just be a solid mass, an amorphous mass within the lesion. So clinically, appears similar to odontomas and often associated with a missing or an impacted tooth. And we'll also find it in the same age groups as the odontomas and ameloblastic fibromas, with no particular sex predilection. What about the location? It's mostly posterior aspect of the mandible, and the epicenter will be closer to a developing tooth or toward the alveolar crest. And the periphery is usually well defined and sometimes complicated. What's the internal structure? So you can have both mixed, and majority are radiolucent. Then small lesions may appear as enlarged follicles with only one or two small discrete radio opacities. So those are smaller lesions. They may just appear like they are follicles that have been enlarged with some one or two discrete opacities within them. Then the larger lesions have more calcifications, and this is most often associated with an impacted tooth. We have an example there. It's an oblique lateral showing a large expansive ameloblastic fibroadenoma, which is arrowed there, the mandible of a 5-year-old child. The internal calcification is comparable to tooth tissue, and the histopathology confirms the presence of enamel and dentine. So this is a lesion there. You can see it's areas of radiolucency, but a larger part of it has calcification. And you can see a tooth there. So the density of this radio opacity, it resembles the density of the crown of that tooth which is impacted. Okay, we continue. Sorry. Let's get to where we were. That is calcify. Okay, so now the last lesion is a benign cementoblastoma. So this one will occur in adults under 25 years old, and then it's rare. We haven't seen it much in our setup. And then located at the apex of the mandibular molars or the premolars, or about the size to be variable about 2 to 3 centimeters in diameter. And then the shape is usually round and may have an irregular shape. Sometimes it's described as resembling a golf ball and it's attached to a tooth root. So it's usually well defined. What's the internal structure? So as we are talking about mixed lesions, so it's mixed and largely it's radiopaque. So the pattern is amorphous, and we have a wheel spoke pattern, like the wheel of a bicycle. Then the density of the cementum mass usually obscures the outline of the enveloped root. So usually you don't see the apex of the tooth because all of it is covered by the lesion. So we have a central radiopaque mass that's surrounded by a radiolucent band, which indicates that the tumor is maturing from the central aspect, moving on to the periphery. So you'll find these are outer zone of osteoid, the area that is not well mineralized with the less of the of calcification, so it will appear radiolucent. So it's often surrounded by a diffuse area of sclerotic bone. This is a reactive bone that is reacting because of what is going on, because of the tumor that is growing and dissolving bone. And then the normal bone tries to, it reacts and it becomes sclerotic. What are the effects of surrounding structures? So we've seen that it's normally attached to a tooth root, which is usually obscured as a result of resorption and fusion to the tooth. So it causes root resorption. So if enlarged, it may cause a localized expansion of the cortical plates. So this is an example of it. So this is a periapical radiograph. This one is showing us a radiopaque mass at the apex of the forceps. So this is like the so-called the golf ball appearance. And then the mass is attached to the root and has a thin radiolucent line around it. And the bone around it is sclerotic. So we are done with the lecture. So these are just 3 radiographs for you to identify what they are. First, you talk about the location, then talk about the periphery, then talk about the internal structures and any effects that you can see to the surrounding structures. So for further reading, I can refer to the maxillofacial radiology books by Eric White and Farrow. Thank you.